Thanks everyone for joining. My name is John Carney. I'm a first year resident at Sutter Alta Bates down in Oakland, formerly a medical student at the University of Washington in Seattle, hopefully eventually ending up back in Seattle at some point. That is the place that I call home, and that's where I'm hoping to practice in the future. And I know we got some other folks here. I think most people here are in the greater Seattle area. David, I think you had some announcements that you wanted to kind of update everybody on. And then we usually like to include other people if they have announcements for other events that are coming up or petitions, anything like that. Please feel free to share them here.
I have three announcements. The first one, Washington Physicians for Social Responsibility is having their annual, quote, Health Justice Benefit Gala and dinner, and it'll be on Saturday, September 19th, 5:30 p.m. Broccoli Conference Center, which happens to be in West Seattle, South Seattle College in West Seattle. And it's Dr. Steve Brzezinski will be the keynote speaker. Many of you know him from University of Washington. His usual focus is on how critical the first month of a baby's life is for determining actually the rest of their lives, and particularly how inequality, quote, kills us all. So inequality in a baby's first month or two is just determinant. Second, PNHP National Organization's annual meeting is going to be in Chicago, November 13th to 15th, and it's focusing on Medicare for All strategy after we see what happens in the midterm elections. Our chapter and Associated Students for a National Health Program will have at least 10 members attending, and we will be reporting back at our PNHP Washington November 18th monthly meeting after that. And that should be a pretty exciting meeting. Last thing is PNHP Washington has been tasked to have a house party to help raise some funds for the national organization by bringing in new people and so on. And this will mostly be a social get-together for new residency students coming into this area, LAPS PNHP members, and basically friends who are interested in health policy and particularly advancing Medicare for all. It will be on a Sunday afternoon. It'll be a barbecue with approximately 30 minutes set aside to include information about our chapter and fundraising asks for small donations for the National PNHP organization. So we have a proposed date for this house party, August 15th in West Seattle, but we may postpone it for a month or two. It's not a hard date yet, but so you'll be hearing more about that.
So next, I would like to do a brief land acknowledgement. I'd like to do a land acknowledgement for what we call today the state of Washington. And I want to acknowledge that we gather on the ancestral and unceded homelands of the indigenous peoples of what is now called Washington State. We honor the sovereignty, resilience, and enduring cultures of the many tribal nations who have cared for these lands and waters since time immemorial, and we express our gratitude for their continued stewardship. Next, I want to go ahead and introduce our speakers. So we'll start off with Dr. Barnett. Dr. Heather Barnett is a board-certified physician in physical medicine and rehab and assistant professor in the Department of Rehabilitation Medicine at UW. She specializes in management and treatment of people with spinal cord injuries and other neurologic issues at Harborview Medical Center. She is the director of the Northwest Regional Spinal Cord Injury System, which provides education, resources, and engagement opportunities for people with spinal cord injury, their friends and family, and medical professionals. She is passionate about improving care and outcomes among people with spinal cord injuries at both the individual and systems level. Her research focuses on improving health equity in the delivery of rehabilitation care. So welcome, Dr. Barnett. Next, we'll go to Dr. Brzezinski, who's an assistant professor in the Department of Rehab, Division of Physical Therapy at UW. She's a board-certified specialist in neurologic physical therapy with clinical experience across the continuum from critical care to community-based rehab in the United States and Haiti. She co-directs the Advancing Health Services and Rehabilitation Aspire Lab in Department of Rehab Medicine and holds multiple leadership roles in the American Physical Therapy Association. Her research focuses on intersections between health and reimbursement policy, therapy practice, and patient outcomes in post-acute care. So thanks for joining us, Dr. Brzezinski.
Yeah, so thank you guys for having us. The general things I wanted to talk about today, first I just wanted to talk about disability a little bit in general. I think medical education, at least for physicians, doesn't always do a great job of covering disability as sort of a general concept and something we need to be aware of. And then I'll talk a little bit about healthcare and disability and why those things are so closely intertwined. And then we'll talk about access to rehabilitation as part of sort of why we need healthcare reform in the current system. And I think a lot of that will be Rachel's recent research. And then just briefly talk about, what might things look like if we were to have some changes to our system. So to really start from the beginning, I wanted to go over, what is disability? I think this is something that I think, especially for physicians, there's kind of the idea that we'll know it when we see it, right? I don't need a definition, or I don't really need a way of thinking, I'll figure it out as whatever. I kind of know what that means. And if people have definitions, you're welcome to share one. But I think really when I think about what is disability, it's a really hard thing to define in just a one sentence or two way. And this is just a little bit of more detail about, limitations and knowledge about disability. So there are a couple of related studies, a group, including, I think the person, Lisa, I can't pronounce her last name, but she has multiple sclerosis and has done quite a bit of work in this area. They surveyed over 700 physicians. I think this is in Massachusetts. And the majority of people basically said they don't know a lot about the ADA. The majority of people had an incorrect response to who determines accommodations. And all they really wanted for an answer for this was that it was both the patient and the provider who determines what accommodations are needed in terms of accommodations in a medical setting to serve someone with a disability. Who pays for accommodations? Most people knew that it is the facility or the provider. And then people actually perceived that they had a bit of a risk of they could be sued if they're not providing care. There's a lot of physicians' offices that don't have accessible equipment to do an appropriate exam for someone with a disability. I think perhaps, at least to me, a little more concerning is some of the attitudes around disability among physicians, with over 80% of people reporting that people with a disability have a worse quality of life than disabled people, which there's other research to show that first of all, quality of life is a subjective measure, right? There's not like a scale you can put it on and determine what is someone's quality of life. It's really how they perceive it. And there's a huge disparity in terms of what physicians think someone's quality of life is or will be compared to how a patient self-rates their quality of life. And patients with disability, particularly relevant in the spinal cord injury field, patients will rate their quality of life much higher than most physicians who work with them. About 40% of physicians were confident about their ability to provide equal quality of care to patients with disability, which hard to say if it's high or low, to be quite honest. And then this number seems low. Only about 50% of people said they would welcome disabled patients into their practices. And less than 20% said that the healthcare system often treats patients fairly. And this is actually from their first study, but what they said is that these findings underscore the need for more training about disability and disability civil rights, which I think is clear from the results of those studies. Some other findings were that in physician training, as I mentioned, disability is often not really discussed very much. It's often framed as kind of a problem with these certain individuals. They have these problems or those problems that causes them not to be able to do certain things. And then negative ideas about disability really have a huge impact on both diversity in medicine, but also the care, I think, that is provided to patients. And if is made in curriculums, it's often led by individuals, not, ACGME is not leading an effort really to like improve education about disability. Here's a list of suggestions, which I don't want to get into entirely in too much detail, but these are some recommendations they came up with about improving disability education or disability conscious medical education, including recognizing different types of disability, moving beyond the medical model of disability, which we'll talk about, developing respectful curiosity, continual engagement in learning, and to center individuals with disability when we're thinking about that and teaching about disability. When I think about what is disability, I think it's really more well described by models than like a singular definition, right? And the medical model of disability, which is kind of what's historically been used and shown on the left here, is basically you identify some physiologic problem, which is often called an impairment. Like, someone might be missing a leg, they might not be able to move their legs, things like that. And that's how people have historically defined disability. And kind of left it at that, very much the medical diagnosis that makes them different or abnormal, and limits some physiologic function. I would say on the far end of the spectrum is what is sometimes called the like strong social model of disability, which I think is really helpful at least to know about, because it sort of positions disability as not a problem with the individual, but the idea that society does not provide people with accommodations, right? And there are barriers for people to do their activities of daily living or to achieve mobility that they need because of barriers, right? So the problem isn't that you can't walk. The problem is that you're not provided with a wheelchair and you don't have elevators, you don't have ramps, things like that, and really shifting the focus to the system. A lot of models, I think for many of us in medicine, many of those who work with patients with major disabilities understand that there's, kind of there's an interaction, right, between the person and their environment, and that's really what disability is about. And we try to make the environment match the patient a little bit better and provide them with the things that they need, despite whatever physiologic difference that they have. One of the most common models that we use in rehab and that is used around the world is the WHO's International Classification of Function model, which at the top here you have somebody's health condition. That might be something like a spinal cord injury, multiple sclerosis, schizophrenia, something that's an abnormal physiologic disease process or just characteristic. And then we think about impairments as things like if you have a spinal cord injury, you might have paraplegia. You might not be able to move your legs. If you have schizophrenia, you might have, hallucinations or something like that, a very specific abnormality. I think multiple sclerosis is a good example because people can have lots of different impairments. They might have paraplegia, or they might have fatigue, or they might have something else that impacts their ability to do their ADLs or activities and participate in their community in the way that's normally expected, right? And I think it's important to kind of understand that that's contextual and that depends on the expectations of your community, your society, and like your age group, right? So someone who can do something who can't do something and they're 20, well, that may be a disability. It may not be a disability for someone who's 5, right? So there's a lot of context that goes into this. The environment can be disabling, or it can be enabling, right? Some of the things that we often don't think of as a disability really depends, really, I think, is because our environment has provided people with adaptive equipment or features that allow that physiologic condition to not be a disability, right? So we can talk about like, I have glasses, I'm nearsighted, right? it's not too bad, but it would be a problem for me if I didn't have glasses. But we don't really think of that as a disability because it is so normalized to wear glasses. That also brings up that, I have vision insurance and I can go get glasses when I need them, and some people don't have that ability, right? And that's another way where disability is very dependent on not just your community and society in general, but specifically what you have access to as the individual. And personal factors, I'm not going to go into a whole lot, but there's sort of the idea that people adjust to their disability differently and approach their disability differently. Here's more examples, but I think we went into enough. So now I want to talk a little bit about healthcare and disability and why this is such a huge topic, especially now with Medicaid cuts and all of that going on. So for healthcare needs among individuals with disability, there are huge needs for healthcare and a huge amount of interaction between individuals with disability and the healthcare system. A couple of points that I'll make. So there is an increasing prevalence of disability over time. There are high healthcare needs as well as costs. A lot of people who have disabilities already are on public insurance at much higher levels than individuals without disability. And that also, as I've sort of been alluding to, at least, there are big disparities in care between people with disabilities and people without disabilities. It is, or at least was, recognized by the NIH as a health disparity population fairly recently, but also that was fairly recent. So this has been sort of a neglected area of health disparities in the past. I think it really is interesting to think about the increasing prevalence of disability and how that impacts the healthcare system and how that impacts people with disabilities. And there's a really nice article that is cited, probably cited in my notes somewhere, but where I got a lot of this from. And they kind of made 3 points that in some ways, the US has made progress, I guess, in terms of reducing the incidence of preventable disability, particularly with workplace injuries and motor vehicle collisions to some extent. But I think in a lot of ways that's outweighed by, one, the aging of the US population, which is changing medicine dramatically. And older individuals are at higher risk for developing some limitation physically or in other ways that impacts their function. And then the other thing is, as we've become more and more successful at treating acute diseases, right, and developing treatments for chronic diseases, that means that more and more people are alive who have conditions that either are or can be disabling, right? And so I think of course, preventing things that are preventable is great, and we certainly want to prevent car crashes and workplace injuries and things like that. I particularly work on looking at disability and violence, injuries that are due to violence. And those are all wonderful things to prevent. But, when diseases become chronic, when HIV became really a chronic disease instead of an acute disease, that means people live with the chronic consequences, which often involves disability. And I think, so to me, that's not, this increasing number of people with disabilities doesn't necessarily represent a failure. It's just, it's in some ways, it's success of our system in keeping people alive. All right. As I mentioned, there are huge costs for medical care for individuals with disability. And some of that is kind of inherent to disability, meaning that often people need equipment or some sort of accommodations to address their disability, right? That includes adaptive equipment and durable medical equipment, or DME, which many of you are probably familiar with, and those things cost money. The other, I think, kind of to some extent inherent cost to the system, whether or not that is paid for by healthcare, is caregiving, right? Many people need assistance with their ADLs or mobility, and that means another person has to help them, and that is a job. Whether we pay them or not, it costs. It has costs. Um, the other thing that this paper that I mentioned, which I can add to the chat or something, um, there's a lot of risks for secondary complications. So for an individual with a disability, often they have impaired reserve, meaning they're operating kind of along the line of if there's a decrease in what they're able to do or they get an infection or something, that's really going to affect them a lot more than someone else who maybe has more reserve. There are also disparities in preventative care and other kinds of healthcare that cause more medical problems for individuals with disability. This is some graphs I'm not going to go into in a huge amount of detail, but basically, this is showing outpatient visits, and I think for those outpatient visits, like the number of prescription drug fills for individuals with either no disability, which is the dark bar, moderate disability, or severe disability. And what you can see is that as you increase the amount of disability someone has, they're getting more outpatient visits and needing more prescription medications. This also comes with increased costs, and this is looking at financial hardship, meaning people having difficulty meeting their financial burdens. And so basically people with, particularly those with severe disability, have high financial burdens, with some of them having catastrophic financial burdens, family having problems paying medical bills, and family paying more medical bills over time. People with disabilities account for a pretty large proportion of spending in the US healthcare system at both an individual level and a total level. So on the left, I believe this is per person. In some way. I don't actually know what those numbers mean now, and I don't have the notes, but you can see that the expenditures are much higher for people with disabilities in that dark color. And also the out-of-pocket expenditure is much higher. And then this other graph is sort of the percentage of these categories of expenditure that are related to people's healthcare, people who have disabilities and their healthcare, versus this like line across is the percent of people with disabilities at this point in time, which was 1996. So these are somewhat old data, but I think probably pretty similar today. These are just a couple of examples of costs to give us kind of somewhere to have a benchmark. So for individuals with spinal cord injury, someone may need a specialized wheelchair. So this is a wheelchair for someone who has a neurologic issue and needs a highly specialized wheelchair, not the one you pick up at the Access medical store that you go to that has the little like scooter thing. This is for someone who's going to use this all the time. And those are $20,000 to $50,000. And they need to be replaced about every 5 years. So that's essentially buying a car, right? And that is paid for typically by insurance, with some limitations on what they will allow for people, but it's a pretty big expense. And I think the other thing is a lot of this stuff is quite specialized. So while we talk about kind of profit and drug companies and that kind of stuff in medicine, I think a lot of this is frankly, in my opinion, not really markup. You know what I mean? Like these are not enormous companies making these like New Motion and stuff. These are not humongous companies that are like, it's not like the Eli Lilly, insulin ripoff scam. This is like, that's how much it costs to make a wheelchair like that. And this is an ultralight manual wheelchair, so this might be for someone who has paraplegia, meaning just legs are involved. That's maybe, I would say, buying a really nice bike instead of buying a nice car. Also replaced about every 5 years. And then I'm sure you all are familiar with catheters. This is intermittent catheter, meaning somebody takes like an in and out catheter. These can be $1 to $10 at a time, depending on if you get the nice kind or not. 4 to 8 times a day, basically the same number of times you would pee. And this is out of pocket costs. So private insurance over $1,000 a year, public insurance about half of that, is some recent data. And as I mentioned before, a lot of people with disabilities are already covered by public insurance. So this is looking at basically comparing people with some limitation, either in major activity, whatever that means, or an ADL limitation. And you can see that for both, that public payer line, which is the darkest, is much higher than it is for people without limitations. So there are a lot of disparities for individuals with disability. A lot of assumptions get made, right? Like we don't need to provide this person with reproductive counseling, or we don't need to talk about smoking. This person isn't going to smoke, whatever it is. A lot of assumptions get made. Much decreased rate of cancer screening. There appear to be some reduced vaccination rates. There's a huge lack of access to dental care. Some of this has to do with, again, assumptions. Some of this has to do with like, there's literally not a chair for you to get onto. Or, there was a study of women with disability who were pregnant, and like a substantial number of those people said they never got weighed during their entire pregnancy because there was no way for them to get onto a scale in their OB office. All right. And I want to make sure to give Rachel some time to talk about her really interesting stuff here.
Okay, Heather, I have a few just thoughts to add from that. One thing is from the rehab side, I love that you put the ICF model on there, because as physical therapists, we do have, I think, an ableism problem. We're all about improvement and getting people back to their level of function. And I think that can be really challenging for people with disabilities. And part of that is the payment model, that we have to justify our services based on how people are getting better. And that is just a really challenging thing that can occur for people with disabilities with some payers. That said, there's a lot of great rehab needs that can be filled by a physical therapist for people with chronic long-term disability. And as many of you probably interacted with your rehab colleagues, all the wheelchair fitting, all of the participation enabling, potentially more compensatory strategies. We're not really always looking to get people better. We're looking to get them to participate better. So it was just kind of a thought, and I'll call everyone's attention in this group to the JIMO settlement. I'm not sure if people are familiar, but it's relevant for the disabled population, and I can't even remember. It's been around maybe 15 years now. But basically, Medicare used to not pay for rehab for people who weren't improving. And so for people with disabilities, that was really problematic, because they may not actually improve in things like mobility or pain, but they may have, better participation in their life. But the JIMO settlement made it so Medicare specifically said you can qualify for rehab services to maintain levels of function. So I think that's just something that is important, because I think still to this day, there's this perception that people who aren't going to be able to improve shouldn't get rehab care, and that's not the case, especially in the Medicare population, which also applies to most other payers. So speaking of payers, I'll talk a little bit about access to rehab care. So this is kind of for everyone. My work is primarily in the Medicare population. That said, people with disabilities do not have to be 65 to be covered by Medicare. It is challenging. You have to be on Social Security and disability for 2 years before you can be on Medicare, which is part of why there isn't as much part of why folks take time and often have to have Medicaid only for a while when they're newly disabled. But a lot of younger folks with a disability will be dually eligible for Medicare and Medicaid. So this kind of information will apply to that population as well. So I have a little bit about kind of access to rehab in the system, and this is content that I give some of our physical therapy students who literally get no education about health insurance, which may or may not be true in for physicians as well in school, and really the continuum of care and what is actually covered, and some of the evidence around outcomes. And then I have a little bit on Medicare Advantage, which I do a fair amount of research on, but I know this group is going to be pretty familiar with Medicare disadvantage, as we call it. But I have a little bit of information on kind of outcomes, comparing Medicare Advantage and traditional Medicare. So this, I'll just start with this. When talking about access to rehab, Medicare disadvantage. I love this graphic, which is like, when do people interact with rehab in the system? It could be in any of these sort of buckets along the care continuum, and it's not a continuum because as we know, it's not a straight line. People will enter the system from all sorts of different ways and transition between types of care. So I don't know, you want to go to the next slide, Heather? So I call it a dumpster fire more than a care continuum. But I'll talk a little bit about kind of the three main post-acute settings, which often, if you're newly disabled, this is sort of part of your care trajectory, is going to one of these post-acute settings for rehab. Or anyone who has sort of a disabling, whether it's temporary or not, hospital stay. So the three settings I research the most are inpatient rehab facilities, or IRF, SNF, and home health. And I think it's just nice to kind of figure out what the differences are between these settings, and many may not know, especially if you're starting out in your medical career, what the difference really is. So IRF requires a 3-day hospital stay. And this is, when I talk about requires, I'm going to mostly be Medicare requirements, but they apply largely to most commercial payers as well. So admission to an IRF requires a 3-day hospital stay before you'll get your IRF stay covered. And patients have to, then all of this has to be documented, which Heather is probably much more familiar with as the one responsible for much of this documentation as a physiatrist. The patients have to require at least 2 of the 3 therapy disciplines. So PT, physical occupational therapy, and speech language pathology. If they just need one, they do not qualify for IRF, and they have to have a documented ability to tolerate intensive therapy. So IRFs are not a place for really medically unstable folks who can't participate in at least 15 hours a week of therapy services. And they also have to have a documentation that they require interdisciplinary coordinated care and the frequent physician supervision. So it's obviously the least utilized of the 3 settings, partially because it is the most challenging to get into because there are all these requirements, but also it's the most expensive, which we'll mention in a minute. Skilled nursing facilities are much more common. There's almost 15,000 different SNFs around the country, and there's only like 2,000 or 3,000 IRFs. So SNFs are kind of sort of the IRF replacement in a lot of ways, but they are very different. They do still require that 3-day hospital stay that was waived during the COVID pandemic, but it's back. So you still have to have a hospital admission. And their only requirement is that they have to need either daily nursing or therapy services. And then I think there's the next slide. We'll talk a little bit about the differences in care. Home health, on the other hand, doesn't require a prior hospital stay at all. So you can be a post-acute home health recipient or community entry. So if a community physician, if your family physician says you need home health, you can qualify for home health. And the requirements are just intermittent skilled nursing or therapy services, and they do have to meet homebound criteria, which I think a lot of physicians think are more restrictive than they are. A lot of people can be homebound and still be going to church or still be going to their doctors, as long as it's defined as unable to leave home without considerable difficulty, you're still homebound. And I think Medicare has specified that, like, religious exceptions and medical exceptions count. So people shouldn't be disqualified from home health if they, do access medical care. Can you go
And
on?
I think the actual, like on the form now, it's like requires the assistance of another person or device to leave the home. So it's
Yeah.
quite, for individuals with disability, a lot of people can get home health.
Um, so just like there's a lot of differences between the requirements, there's a lot of differences in the care people receive. So for therapy, IRF stays are typically short and they're getting shorter and shorter. When I was training, even not that long ago, 15 years ago, the average length of stay in an IRF was over 2 weeks. Now it's less, it's only 12 days. So these are really short-term intensive stays, but they are getting a minimum of 15 hours a week of therapy services, and they have to receive at least 2 of the disciplines. SNF stays are much longer, about a month on average, and this is a lot of the work that I do, there is no minimum amount of therapy required. And it varies a lot, and it has declined in recent years. On average, patients are getting about an hour a day of therapy combined between the 3 disciplines. So that's at least a third, if not less than what they get in an IRF. And then home health, because patients are at home, their episodes are much longer, on average about 2 months. Similarly, there's no requirement for how many visits they receive by therapists. OT is used very sparingly, and so is speech in home health. So the dominant discipline is physical therapy, and on average, patients are getting about a visit a week. So you can go to the next slide. And then medical care also varies. So this is another one where Heather might have to correct me a little bit. But in IRFs, you have to receive face-to-face visits with your provider. IRFs are required to have 24/7 registered nurse staffing, and they're required to staff an interdisciplinary team, including social work, all the therapy disciplines, and then rehab psych and prosthetics and orthotics. In a SNF, there is no physician requirement. They have to just be available in a case of an emergency, which if you think about how medically complex a lot of these patients are, it can get pretty scary pretty fast. They only have to have an LPN or an RN on site 24/7, and there's no minimum staffing requirements for any of the like CNAs or actual for the nurse disciplines besides that 24/7 requirement. There's been a lot of debate, and actually under the Biden administration, CMS did institute a minimum staffing standard across all SNFs in the US. It was canceled by the Trump administration. So as it stands, SNFs do not have to staff anybody except for an LPN or a nurse, 1 person, and the average bed size for these facilities is over 100 beds. Home health, there's a requirement to have a face-to-face initial visit with a provider that can be on telehealth. And they get about 9 visits per episode from nurses. Again, those are about 60 days long on average. Home health aides, patients do qualify for aid services. So this is like the day-to-day care under the home health benefit, but they're not utilized a lot. And there's a lot of interaction between like Medicaid services and home care services, and being a replacement for home health. And then social work is, again, very, very infrequently used. So that's just kind of an overview of the settings themselves. There are differences in outcomes for certain patient groups going to these settings, which we could, have another 3-hour conversation about. But again, IRF stay is the most expensive for an entire stay, despite it being much shorter, is about twice the cost for IRF. And there are copays as well. IRF, they kind of get higher copays over time. SNF, the patients have a copay after about 20 days, but in home health, there's no copays. I think we can talk a lot about Medicaid cuts, but basically the hospital is the end of the line for all sorts of cuts, whether that's cuts to your post-acute care or cuts to Medicaid. And as probably all of us know who've worked in a hospital setting, the payment system for hospitals incentivizes hospitals to get people out the door. much faster, and over time, even the hospital patients are getting more and more complex, and we've shown similar rates in skilled nursing and home health. And we are having just already, even before Medicaid cuts, we had a hospital crowding problem nationwide, and because the overall length of stay increased about 20% in the last few years, and that was even worse for patients who needed post-acute care. I don't want to. Payment models are kind of boring. This is the work that I do. But I think it's just helpful for this group is that there were payment reforms right before the COVID pandemic that removed incentives for SNFs and home health agencies to provide high volume rehab services. So as part of that, and you can go to the next slide there, this is research we've published. SNFs especially immediately reduced how much therapy they provided. We saw about 15% reductions in therapy staffing, like the week of this payment reform. Patients are also receiving fewer therapy visits in home health. You can go to the next slide. This is a study we published last year that looks at just the minutes per day that patients are getting of rehab services. That red line is the payment policy, and the purple line is the onset of the COVID pandemic. And we found that about 24% reductions in the amount of time that patients are seeing therapists. Over that time period, it didn't get better even as the pandemic kind of wore on, and we found significantly worse declines in for-profit SNFs, of which that's about 80% of the industry is for-profit in skilled nursing, and we found worse declines in rural SNFs as well. And those patterns, again, continued. So what does this mean for outcomes? We just published a series of 2 studies in SNFs, and some are coming out in home health, that, we're seeing these big declines in therapy provision. CMS said it was like a correction, right? That we were over providing, it was low quality care, because prior to these reforms, SNFs and home health agencies got paid more for providing more therapy. It's that, typical fee for service problem. But we did some fun mediation analyses, which really puts therapy volume on that pathway between the reforms and the decline, or the payment reforms and the pandemic and patient outcomes. And you can do some fun math and lots of statistical modeling. And we did this for 3 different outcomes. So the first were functional change. So how patients were doing on their functional measures during their skilled nursing stays. And we actually saw these are just descriptive data. And that red line is during this time period with payment reform in the middle and then the pandemic. Patients were getting worse at a higher rate. So they were declining in function. But there were some people that were doing really well, and that rate also ticked up slightly in the green. So this is like a high level of improvement. But when we put that declining therapy in the mix, which is that blue line, and treated it as a mediator in the model, we saw that we can basically test what the counterfactual would have been, like how would they have done in the absence of that decline in therapy volume. And we found that declines in therapy provision were responsible for about half of the increase in that ADL decline, and 26 right after the payment model was reformed, and then about 26% of that during the pandemic. So it's not 100% of the reason why these rates are going up, but it was a large chunk. And then, of course, we adjusted for everything under the sun. So we're pretty suspicious of Medicare's claims that these payment models and the declines in therapy provision were like a right-sized approach. We think the declines have kind of gone too far. So you can go to the next slide, Heather. And then we saw this is similar, but just for 2 different outcomes, looking at patients readmitting to the hospital within 30 days of their SNF stay and their rates of successfully going home or to the community. And so on that right graph, the purple bars are like what we saw. These were the adjusted rates. So these were the changes in these outcomes after payment model implementation after the pandemic started. And the red is that estimate of what the effect of the declining therapy volume did. So that blue bar then is like that hypothetical situation of what those outcomes would have looked like if therapy hadn't declined to such an extent. So basically, you can see that declining therapy was associated with observed worsening of both, basically all four outcomes when we looked across the board. So yeah, that's kind of post-acute care, rehab access, payment reform stuff. Medicare Advantage, I think we could probably skip the first slide or two there.
Yeah. It's not.
And just talk about, because we all know what it is. We know it's more expensive. We know it's growing. It impacts care. So post-acute care in particular, patients on MA compared to their fee-for-service or traditional Medicare counterparts receive less post-acute care, less rehab, and then once they get there, they're admitted to lower quality facilities and agencies. They have shorter stays and they get less rehab care.
Oh, sorry.
No, that's fine. And then, but the outcomes question is mixed, and there's a lot of back and forth and argument about how MA, yes, they save or they reduce care, but actually might be saving money and being cost effective because outcomes don't move a lot. But that's unfortunately not the case. Especially if you account for the substantial differences between the patient populations. So as we all probably know, patients on MA are much more likely to be from minoritized backgrounds. They're poorer. They're from more urban areas. So they're already kind of at risk. And if you account for a lot of those differences, then some of the outcomes kind of rise to the top of being worse for that patient population. So we can, so this is I think this is a Senator Blumenthal's office report. MA is definitely in the news a lot about not just being wasteful of taxpayer money, but stinting on care but reforms are a hard battle. I think this is what you.
Yeah, I think I put some of this together, and I was kind of thinking. I think some of the the PDMP stuff that you have is sort of people trying to Medicare, traditional Medicare, trying to cut costs, and I think this prior authorization and denial business is really Medicare Advantage is one of their major ways of trying to cut costs, ultimately getting less therapy and rehab care to patients. This has become a huge issue in post-acute care. For those of you who are not directly involved, this is really getting to be, I think, crisis levels, to be honest. And there are a number of lawsuits against a number of these insurers related to this, but it's a big problem. And I will just say that at least in the Seattle area and our local area, United Healthcare is generally the worst offender. And you can see here that a couple of things. First of all, the denial for post-acute care, which is PAC in this how they're abbreviating it here, compared to their overall denial rate's been pretty steady between 7 and 8%. Post-acute care started about 8%, but is now close to 23%, close to a quarter of post-acute care prior authorizations are denied by all three of these kind of worst offender groups. This is looking at denials to LTAC or long-term acute care hospitals, inpatient rehab facilities, and these are these are pretty crazy numbers. Of United Healthcare denying 66% of inpatient rehab requests, CVS initial denials. These are initial denials, 80%. And then one of the things, interestingly, that these reports noted is that these high rates of overturning things suggest that this is a problem, right? It's not like, oh, great, you got it overturned anyway, because a very small amount of initial denials are appealed. So what you're saying is for the people who bother to appeal, it actually turns out that they did need that care, and that the denial was not appropriate. So a huge amount of missed care for patients. This is looking at SNF denial rate on the bottom. And what the colors are, so these three corporations, Humana, CVS, and United Healthcare, provided the majority, and we're three of the top. And yes, IRF does, yeah, they fall under Medicare Part A. So, but then 95% of SNF denials were overturned on appeal, which is pretty nuts. There's also, which we won't get into today, a lot of use of third-party prior authorization reviewers and peer-to-peer systems, which is part of the problem, we think. But yeah, just really, really large amount of denials. So which is part of, I think, the backup into hospitals, because as people wait for peer-to-peers to be scheduled or appeals to be done, they wait in the hospital. So this last part, why do we need healthcare reform for individuals with disability, or how could that help? I think some of that is hopefully evident from what we've been talking about, but I'll talk for a few more minutes. What would this do? So, what I've just been talking about, eliminating prior authorization and profit-driven decisions would be huge, right? That is a huge issue for this population. It is a costly population, and so people are trying to cut costs, and it really cuts care for this patient population. Some other things, decoupling employment and insurance. A lot of the unemployment rate is pretty high for individuals with disability, and many of them are relying on public insurance anyway, but that idea that you should be working to get insurance for this population is a particular issue. Ideally, maybe if we had healthcare reform, we could address asset limits for Medicaid. Because people with disabilities who depend on Medicaid, this is a whole separate discussion, but Medicaid is really the only insurer that provides caregiving services. No other insurer pays for caregiving. And so if you require caregiving to be alive, you sort of have to be on Medicare or Medicaid, excuse me, have to be on Medicaid, which means you have to be poor, and you cannot accumulate money. That is a huge problem. There's Medicaid, as you may have heard terms like Medicaid spend down. There's also issues with people not being able to get married or needing to separate and things like that because of income limitations. And ideally, which is what I'll talk about at the end here, ideally a system that would have more coordinated support for long-term care, including, facility-based care, but also community-based caregiving and support, which I'll talk a little bit about. We do see in peer countries to some extent, and I don't know a ton about this. It was interesting to look at the only category of spending that the US spends less per capita on in healthcare is long-term care. So other peer nations, which in this case, they looked at Austria, Belgium, Canada, France, Germany, and the Netherlands, Sweden, Switzerland, and the United Kingdom. All of those places spend much more per capita on long-term care. And you can see that here it also as a breakdown. So other comparable countries spend about 20% of their healthcare spending on long-term care. The United States spends less than 8% on long-term care. And then the numbers are here as well. So that's a greater percentage and just more gross money, dollars, that other countries spend on long-term care. The rate of growth in other countries is also increasing. It has increased more compared to the United States. So over, I guess this is like 8 years. long-term care spending increased about 5% in the United States, and in peer countries, almost 20%, which, I think they have concern. I'm sure they have their own concerns about increased cost. However, I think given increase in incidence and prevalence of disability, it's not too surprising that there is a need for increased spending in this area that we in the United States are particularly not meeting. Closing thoughts. We've been all over the place with this, gone through a lot, I think, with this talk. But I think, just pointing out that improving our understanding of disability and support for people with disabilities is really important in the healthcare system in general, regardless of the payment model. That's sort of a separate, educating ourselves, those kinds of things are not necessarily, at least not entirely, dependent on the payment model. Individuals really with disability really require quite a bit of healthcare, and their care in particular is a target for profit systems and models, right? And some of that I think is also this question about what is medical necessity, and things like IRF and SNF care being a little subjective in terms of what the indications or what the needs are. And we talked about these limitations to post-acute care, and I think, like I mentioned, this is really getting quite a bit worse right now, quite quickly. And I think finally, as we were talking about, healthcare reform would mean a huge amount to individuals with disabilities. It's a huge concern right now among individuals with disabilities. But I think, to be honest, some of that is going to mean increased. This is not where cost savings from healthcare reform is going to come from. And I think that's a good thing for us to just, I think all of us as healthcare providers, your goal is to provide care to your patients, right, and get them what you need, not to save money. And while not spending extra money and not giving profits to insurance companies or drug manufacturers is important, we also have to address the fact that like providing healthcare to humans costs money, right? We pay nurses, we pay therapists, that costs money. And this is an area where we're currently, I mean, even relative to other countries at a like truly numeric level, we are underspending. That is, I'm sure over time, but I would be happy to take some questions if people want.
Hey everyone, yeah, no question, but I'm just thinking to myself, you pose such a like, I'm embarrassed to say that like trying to come up with like a cohesive and comprehensive definition of disability. I've been racking my brain over it for like the last hour and 15 minutes or so, where we traditionally think of it as being like a physical limitation. Oh, somebody who needs a wheelchair, somebody who needs an orthotic, etc. But I think when you take a step back and you think about not only just bridging someone from where they're at to activities of daily living, but bridging someone from where they're at through that and beyond to, kind of living a fulfilling life, right? And I think there's a lot of shortfalls that, we're not addressing in some of these conversations about how do we get people to live like their best lives, not just survive, right? How do we get people to like survive and then be able to wheel themselves out of the hospital and then, send them on their way, which I've heartbreakingly done with some patients when they're not accepted to SNF, not accepted to an IRF or LTAC or something like that.
Yeah. Yeah, and I think some of that gets too into like medical necessity, like even Medicare, they will pay for a wheelchair only if the patient needs it in their house, because it's not considered medically necessary for you to go outside. That's like not a medical need, that's a social need or whatever.
Right.
So we have to, if we're going to order someone a wheelchair, we have to say they need it for using inside of their house. They need it in the house. Which is crazy, but that's where we're at. I think David has his hand up, maybe.
Yeah, I had a couple of questions. First one, from personal experience in my family, somebody's discharged from a hospital to a SNF. Medicare will only pay for 30 days in the SNF. Is that true? And then after that 30-day period, they have to, I don't know, qualify for Medicaid or
Not
or
exactly.
hospice or hospice.
Right.
Go on to
They still qualify for up to 100 days. 30 days is when the copay starts.
copay. I see. And
Uh, and then so often SNFs will try to kind of get patients out because they may or may not, have a good Medigap plan that would help them cover that copay. And patients often don't want to pay it, but
so can the SNF kick them out if they don't have the money to copay?
Mhm.
They can. Because
Yeah, it's not like a hospital that's required to serve everyone. It's, I think, very hard to actually do it in practice. But what SNFs do is kind of upstream. They don't accept patients that are, on Medicaid. They're not required to accept patients with payers that are unfavorable. So that's a lot of what we're seeing for even MA plans that pay, 60% of what a traditional Medicare plan would pay. SNFs and home health agencies just aren't admitting those patients, and they rely on a traditional Medicare patient mix to subsidize the other payers.
So as far as hospice, will Medicare pay for hospice?
If they meet the criteria,
There
yes,
you
they
go.
have to have that 6 month
Yeah.
diagnosis, and that's certified by what, two providers or something.
The other question is about Medicare deprivatization. PNHP did a study and looked at each state and how much the state would save from deprivatizing the companies, most of them for profit, that run their Medicaid programs in their state. So is that something that is on your bucket list for advocating for deprivatization of Medicaid?
Medicaid or Medicare or both?
Well, we know about Medicare Advantage, but
Mhm.
Medicaid in the states is, I think, most of the states have privatized Medicaid
Right.
At least to
companies
some, yeah,
running.
some of it,
Yeah,
yeah.
like through an
Yeah. Yeah.
MCO.
Yeah.
Yeah.
Um, yeah.
And that PNHP study looked like you could save about half of that money and return it to the states to use in other ways for the disadvantaged people.
Mhm.
Hmm.
Yeah, I think a big part of why Medicaid research lags behind is access to data
Yeah.
because it's state run and so different state to state. There are just in the last few years actually like national databases for Medicaid patients. So to even make those comparisons about cost savings for states that do or don't contract with an MCO has really not been possible. So that's my other plug for good data and to continue to fund research.
So it's hard for me to imagine how privatization of Medicaid would lead to cost savings. I think there's this like dream of like, oh, these companies know how to save
They're
money.
efficient.
Yeah, or whatever. I mean, it's denials of care, right? Like that's
Mhm.
how they save money. It's interesting. I think so from that perspective, I think yes, it's hard for me to say like, why would you privatize any of this stuff? Um, it's interesting though how much more of a problem Medicare Advantage is, to be blunt, than Medi and then
Mhm.
MCO type of Medicaid. I mean, we very rarely get denials from Medicaid, regardless of the which Medicaid it's going through. It's just much more rare compared to Medicare Advantage, which is obviously quite an issue.
I
And
did
I
put
don't know why that
something.
is, but it's interesting.
Well, Medicaid has, required covered services. But I put in the chat, there was a proposal to cut all therapy from the state Medicaid plan for adults last year. So
Wow.
any adult on Medicaid was going to lose access to any PTOT speech. And we had to really be like, what? It was like a very surprising last minute addition within our state budget
Hmm.
crisis. So I think in expansion states in particular, we've had like fairly robust coverage for some of those services and for DME, but that is going to be increasingly under threat.
And do you think that that's partially because, like, one, I'm just thinking about the recent trend in the move of Medicaid plans over to MCOs, because it's a relatively being 15 years recent thing of having these Medicaid plans and then having them transition over to like managed care, right? So we all remember like Apple Health when that first started, it was actually pretty great, right? But more recently, we have things like Molina Health and Coordinated Care and all these other, I think United even has like Medicaid plans that they work with different employers or contract through to like, kind of force people into some of these plans.
Yeah, I noticed that your slides say confidential, and this is such great information, and I think others would be interested in it. And when you had your screen sharing, I was doing little screen capture shots. But in terms of getting this information beyond who's on the call today, do you guys go around and do the presentations or like an abbreviated form of this kind of information? Or would it be all right for me to share some of the slides? I can coordinate over email if that's a better way to do it.
Just sorry for the interruption. Just quick addition. I'll just want to make sure that these meetings are recorded and are posted in our YouTube channel. So that just to give context, but sorry for the interruption. If anybody
No.
wants to answer.
Yeah, that's fine. And our department, these are our department slide.
Yeah.
We have a template from our department to, make our stuff look purple and UW-ish. But yes, you're welcome to share.
Yeah. And I put a link in the chat to my bibliography on PubMed because a lot of what I presented has been published. And I think, and there's one that Heather and I wrote together up there. So you can look for other stuff too.
And Jessica, we'll be including some of the resources that we've shared during this meeting, also in the chat, both on our website and hopefully on our YouTube page as well. So we'll be sure to like keep people up to date on different resources.
Thank you. Appreciate it.
As I said, I put out a report of the meeting. I'm hoping to get this out in a day or two. Once I get the link to the edited, video of this meeting onto YouTube, then I'll put that blast out. But usually it only takes a couple of days, and I think I've got some time tomorrow to do it.
Sorry, I just put the link for our YouTube channel on the chat, and we also think might be just sending it later with to our mailing list as well.
Yeah, this is really great stuff. I feel like this could be a talk, especially amongst like medical trainees and medical professionals. I personally am very guilty of just like kind of blindly just ordering like PT/OT eval and then just don't even think about it. But I think there's just such a wealth of knowledge and such a wealth of what PT and OT and SLP and all the other therapies that they can offer for us, like not only for people in the hospital, but also in helping people like get out of the hospital, stay out of the hospital, and really live their best lives. And I admittedly, like I don't know, Omar and Andy dropped off, but I'm just thinking of like how much actual formal training that we have gotten with PT/OT. I know they've had some of those like interdisciplinary like social get-togethers, which are like once a quarter that I may have skipped one or two, but that has like dental and nursing and PT/OT. But I feel like there's just like so much that of what they do inside the hospital that we're not taking, well, maybe we're over taking advantage of and just blindly ordering, or that we don't quite necessarily comprehend to its fullest extent, and how critical it plays in helping patients get out of bed, helping patients like live their regular lives. So yeah, thank you so much for this presentation. And I think part of this discussion is just more fuel to the fire for our fight in trying to like deprivatize a lot of healthcare and work towards, for us personally, like a single payer system where the federal government pays for all services that we deem as doctors, physicians, and physical therapists and healthcare professionals, what we deem as necessary for our patients. And so this is all just like really, really compelling evidence, especially the cost and the denials and the appeals. So thanks for sharing that, Heather. I appreciate that.
Yeah, absolutely.
Yeah. Well, thanks for having us. I'm gonna go run to bedtime for my kid, but
Yeah.
really appreciate it, everybody.
Yeah,
And I put
thanks, Rachel. I
our
really appreciate
contact
you.
in the chat.
Yeah. Yeah.
Thank you so much for joining.
Yeah. And feel free to reach out to us if you guys have questions or need I will try to maybe put some of the references together a little bit from where I got some of this stuff, but happy to share the slides or whatever.
Thank you
Yeah,
so
Heather, just drop it in the chat. Yeah, we'll include it on the recording and the website.
Okay. Great. Thank you guys.
Okay.
Yeah.
So we'll sign off at 05.
Thank
4.
you.
Bye. Thank you.
Thank you so much.
Appreciate it.
Thank
Very
you.
good.
1.
0.
Go Mariners.